Good morning. I'd like to thank the Kandy Society of Medicine and also the Sri Lanka College of Urological Surgeons for inviting me. And the task given to me, as you heard, is childhood urinary tract infections. During the course of this talk, I'd be introducing you to childhood UTIs. Thereafter, I'll be dealing with the old guideline of by the Royal College of Paediatricians and the British Association of Paediatric Nephrologists, which was put out in 1991. It's a very old guideline, but this guideline stood true for a good 25 years, and some units still practice some of the aspects of this guideline. Thereafter, I'll be dealing with the implications of this old guideline and touching on what new evidence has emerged since. And finally, I'll be ending with the current NICE guideline of 2017, as well as the new guideline of the Sri Lanka College of Pediatricians, which was put out last year. So to start with the definition, as always, a UTI in children can be defined as the presence of more than 10 to the power of 5 colony forming units per milliliter of a single organism in a properly collected sample from a symptomatic patient. Now, every aspect of this definition is important. There have to be more than 10 to the power of 5 colony forming units. So 10 to the power of 4 to 5 is not significant. It should be a single organism, so mixed growths are not significant. It should be a properly collected sample, so bag samples again are not significant. And it should be from a symptomatic patient. You should not do cultures, for that matter, in asymptomatic patients. So every single aspect of this definition is important. As you know, E. coli is the commonest cause of UTIs in children, accounting for more than 80%. And childhood UTIs, as opposed to adult UTIs, are important because of the association of these UTIs with reflux nephropathy, which in turn is associated with hypertension and chronic renal failure. So UTIs can have, in some patients, quite significant implications. Epidemiologically, it is well, the lifetime risk is thought to be about 1 to 2% in boys. It's 3 times more common in girls, but within the first 3 months of life, it tends to be more common in boys, as are most infections. And it has also been calculated that more than 10%, that the incidence of UTIs is 10% higher in uncircumcised males. So circumcision is definitely helpful. What makes you susceptible to a urinary tract infection? Now, genital abnormalities in the form of tight reflux or phimosis, as well as labial adhesions, all are risk factors for UTI. So in any examination of a patient with a UTI, you need to do a proper genital examination. Voiding dysfunction can be in the form of a neurogenic bladder, so a bladder issue, which is pathological, but more commonly in pediatric practice, we get a lot of these young schoolgirls who don't like to go to the toilets in school because of for hygienic purposes. So they keep the urine in, and they sort of tighten it and keep the urine in, and basically this goes on for several hours. And that is one of the commonest causes of cystitis in school-going girls. So this also needs to be addressed if it is identified as a possible risk factor. Reflux I've already dealt with, so it's obviously a risk factor. And urinary tract obstruction anywhere from a PUJ to a VUJ to a PU valve, any obstruction puts the patient at risk of urinary tract infections. Now, constipation also is a common entity in pediatric practice, important here because a full rectum pushes the bladder up, and that causes some amount of stasis of urine, and this makes the patient susceptible to UTI. So constipation is another thing that you need to address when you take the history and also when you manage these patients. As for clinical features, now traditionally UTIs in childhood have been divided into afebrile UTIs and febrile UTIs. Afebrile UTIs are also synonymous with cystitis or lower urinary tract infections, where you get the typical lower urinary symptoms or LUTs, where you get dysuria, frequency, urgency, incontinence, and so on. Febrile UTIs are synonymous with pyelonephritis or upper tract infection, and these symptoms can be very vague in young infants and younger children. So there can just be excessive crying, poor feeding, vomiting, irritability. So it can be very vague. So you need a very high degree of suspicion to diagnose a UTI in young infants. Older children obviously present with the more well-known symptoms of fever with chills and rigors, vomiting, and costochondral angular pain. Now, moving on to the investigations, I've just touched on this basic slide just to stress the importance of the simple UFR. Now, all the newer guidelines stress a lot on the positivity of the UFR as opposed to concentrating only on the urine culture. So, both the American guideline and the NICE guidelines necessitate the positivity of both the UFR and the culture to definitely say that this is a urinary tract infection. So the urinary analysis or the UFR will give you the presence of pyuria as well as bacteria, which can be very significant. Culture obviously is the gold standard, and also these the newer strips that are also available now. They basically detect leukocyte esterase, which is basically a marker of pyuria, and nitrites, which is a marker of bacteria. So these also are very helpful in the diagnosis of a UTI. So I want to mention again the importance of the simple UFR in your diagnosis of UTI. Treatment, intravenous versus oral. How do you decide, and when would you go for the IV route? Now, in general, the younger the child, you're going to prefer the IV route. Neonates, the entire course of 14 days should be given intravenously. If the child is under 3 months, again, it is better to give the majority of the course intravenously. If your child is very ill, septic, has definite features of pyelonephritis, again, you're going to start with in the intravenous route. And obviously, if the child is not tolerating oral antibiotics, again, the IV route is preferred. But in older children, once the fever settles, which usually occurs if it's simple UTI, which usually occurs within 24 to 48 hours, you can switch to an oral antibiotic. You don't have to give the entire course intravenously. The duration for a febrile UTI, it has to be 7 to 14 days, and I prefer 10 to 14 days. And if the child is known to have some sort of structural abnormality, like reflux, it's better to give the antibiotics for 14 days, because otherwise there will obviously be a chance of this same infection recurring. How do you choose your empiric antibiotic? Now, this would depend on the sensitivity patterns of your unit. Now, this is not difficult to do. All you need to do is get a medical student or a junior doctor to just do an audit of the cultures over the last 6 months, and you just find out what antibiotic your organisms are most sensitive to, and that would be your empiric choice of antibiotics. Now you need to use coamoxiclav, but cephalosporins are also fine. Another point I'd like to make here when it comes to treatment is the avoidance of nephrotoxic antibiotics like aminoglycosides. Pyelonephritis is a potentially nephron damaging condition, so you should try and avoid nephrotoxic antibiotics like gentamicin and amikacin as much as possible. Now, this is not always possible. Sometimes you can be pushed against a wall where the patient is very ill and the culture is only sensitive to amikacin, then by all means you need to use it. But if there is another suitable alternative, do not use aminoglycosides. Prevention, just to touch on this, obviously maintain good perineal hygiene. In infants, we advise you to wipe the perineum from front to back and not back to front to prevent the fecal flora from contaminating the urethra. Diapers should be avoided because diapers create a lot of moisture in the perineum, which makes the patient susceptible to UTIs. And also you need to change the underwear frequently in kids. Constipation needs to be addressed aggressively. If there are genital abnormalities, phimosis and labial adhesions, phimosis can easily be treated. Apologies to the urologist, but phimosis can be easily treated with the application of hydrocortisone cream in most children. So you don't usually have to go for a circumcision. And labial adhesions also respond very well to estrogen cream. So usually don't have to surgically correct these. It's very amenable to hydrocortisone cream, which can be given for 4 to 6 weeks. If there are structural abnormalities that are putting the patient at risk of UTI, obviously these need to be corrected. And if your child has reflux and is toilet trained, you can get the fellow used to what is called double voiding or double micturition, where you tell the fellow to void and then wait about 2 or 3 minutes and void again. So the refluxed urine will come down into the bladder and he'll void that out. So you get rid of the problem of stasis of urine to a certain extent. And this does help children with reflux to prevent them from getting recurrent UTIs. Prophylactic antibiotics, I'm not going to touch on here because I'm going to deal with it later. Just put it for completion. And now I will just move on to just touch on the old guideline, because I'm touching on this because there are still units in this country that do practice these old guidelines. So this was put forward by the RCP and the BAPN in 1991. It stood true for 25 years, but a lot of problems with this old guideline. Now, if you see this slide, you see that all patients with a febrile UTI had an ultrasound scan and a DMSC. All patients with even a simple febrile UTI, right? So if they were under 1 year, they also had an MCUG, and MCUG, the threshold to do an MCUG was very minimal. If there's recurrent UTI, if there were abnormalities on ultrasound scan or DMSA, or if the patient had a family history of reflux, they went ahead with an MCUG. So a gross misuse, there was a gross misuse of MCUGs here. The old guideline also recommended antibiotic prophylaxis up to the age of 5 years. Now, this is what we learned when we were medical students. Up to the age of 5 years, irrespective of it being a complicated or simple UTI, 5 years of antibiotics as prophylaxis. Cultures were done every 3 months just to see whether there is a recurrence of the infection, right? And if these cultures were positive, these were treated as UTIs. They were treated as UTIs, and also the patient was classified as having a recurrent UTI, and he underwent an MCUG. Imaging, as I mentioned, MCUG was also done for a family history of reflux, and surgical correction was recommended for all patients with grade 4 and grade 5 psychiatric reflux. So any patient with grade 5 and grade 4 reflux underwent surgeries irrespective of whether there were recurrent UTIs or not. What were the implications of this old guideline? There was massive overdiagnosis and massive overtreatment. There was extensive and excessive investigations and excessive follow-up where it was not necessary. And also there was, because of the tremendous investigations that it entailed, there was tremendous radiation and discomfort to the patients. All this came at a tremendous cost and tremendous parental and childhood anxiety. What was achieved? Nothing. There was no reduction in the incidence of scarring, no reduction in incidence of hypertension or chronic renal failure. So researchers looked elsewhere. So what their main focus was on the value of imaging studies, the value of prophylaxis, the efficacy of anti-reflux surgery, the value of doing routine cultures, and the treatment of asymptomatic bacteriuria. Now, what is the new evidence that has emerged? Renal scars have been demonstrated in the newborn, renal scars have been found in the absence of reflux, and renal scars have developed and even enlarged even without a UTI. So UTIs are not the only cause of scarring. They also found that scars are not, it's not usual for scars to develop and enlarge after the age of 4 years. So it's only in the under 4s that you do get scarring. And they've also identified genes responsible. There are several genes responsible for renal scarring and reflux. MCUG is no longer the gold standard to diagnose reflux. A good radiologist with a good machine can diagnose reflux with quite significant accuracy. There is no evidence to support the treatment of asymptomatic bacteria. Prophylactic antibiotics are not effective in preventing renal scarring. Even if you use prophylactic antibiotics, there was no incidence, no reduction in the rate of scarring. And surgical intervention for reflux did not reduce the rate of scarring, nor did it reduce the rate of renal failure. So, with this new evidence, with the finding of this new evidence, came about the new and NICE guidelines of 2007 and 17. And these guidelines basically looked into identifying the minority of patients who really required significant investigations, right? So this is a minority. The vast majority do not require significant or very aggressive investigation. So, what are the features of a patient who would need what are the features of a patient who would need further evaluation? So, these patients were classified as having atypical infections. What are the features of atypical infections? The patient is very ill and septic. If there was poor urinary flow, obviously due to bladder outlet obstruction. If there was an abdominal mass in the form of a palpable bladder or palatable kidneys. If during the course of the UTI the patient had a raised creatinine or deranged renal functions, and if the patient fails to respond to antibiotics within 48 hours, right? And also if the UTI was caused by a non-E. coli organism, like especially Pseudomonas or Enterobacter. So atypical organisms causing UTI. So these are the only patients. So these patients, who have these atypical features, have a high risk of having a structural abnormality. So these patients require further investigation. But the vast majority who have typical UTIs do not need significant investigations. So I'm just going to rush through the NICE guidelines because I'll just touch a little more on the local guidelines that we put out. So as you see in the first column, is there a pointer? That's it, right. So if you see the first column, in children under 6 months of age, if the patient responds well to antibiotics, all you need is an ultrasound scan, nothing else. Atypical UTIs and recurrent UTIs obviously need further evaluation. These for under 6 months. Between 6 months and 3 years, if the patient responds well to antibiotics, they do not recommend even an ultrasound scan. You don't need even an ultrasound scan. Atypical UTIs, you do an ultrasound scan and a DMSA, but no MCUGs. MCUGs are done only if the ultrasound scan shows features of a structural abnormality. Above 3 years, typical, no investigations at all. Atypical, even atypical infections, just an ultrasound scan. MCUG done, MCUG and DMSA done only if there are features of structural abnormalities. So we formulated these guidelines last year. The guideline was published this year, and we've made a few changes just to suit the local context. So if your patient has an afebrile UTI, you don't need an urgent ultrasound scan, afebrile UTI or cystitis, or if the patient has just a simple UTI, uncomplicated UTI, all you need is a non-urgent ultrasound scan within 6 weeks. These are under 6 months of age. These for patients under 6 months of age. Afebrile UTI or simple UTI, just an ultrasound, non-urgent ultrasound scan within 6 months, no DMSA or MCUG. If the patient has atypical features, yes, urgent ultrasound scan, DMSA, and an MCUG. Recurrent UTI, again, we'd go for MCUG and DMSA. From 6 months to 3 years or toilet trained age, afebrile UTI, we recommend an ultrasound scan for the simple reason that in the West, before you are born, you have had several ultrasound scans. So there's a high chance of picking up some sort of structural abnormality, which is not the case in our context. So we recommend an ultrasound scan, which is a non-invasive procedure for patients, even if the UTI is a simple febrile or an afebrile UTI, but nothing else. Right? Atypical UTIs, we do recommend the DMSA as in the NICE guideline, but not an MCUG. An MCUG is done only if there are features of structural abnormalities in your ultrasound scan. For children above 3 years of age, again, the ultrasound, afebrile and simple UTIs, ultrasound scan can be done within 6 weeks as a non-agent procedure. The NICE guideline did not recommend a DMSA, but we have recommended a DMSA because our patients usually present quite late. So between 3 and 4 years, there is a chance of scarring, and there's a lot of treatment of UTIs outside hospital in the private sector. So you do get a lot of patients who have been partially treated. So these patients are at risk of scarring. So because of that, we have recommended a DMSA, especially in the younger child who's above 3 years of age, but certainly no MCUG. What are the other evidence-based recommendations? Positive urine cultures in asymptomatic patients do not require treatment. For that matter, do not do cultures in asymptomatic patients. Routine circumcision is not necessary, but if your patient is having recurrent UTI, you can go for a circumcision. and even severe grades of reflux can be managed without reimplantation. Just to touch on prophylaxis, these should not be routinely recommended in children with UTI, even after the first few years. I see the microbiologist coming in. I'm sure she will agree with me. Prophylaxis breeds resistant organisms. That's why prophylaxis is not recommended. It breeds resistant organisms, and if your child with a complex structural abnormality gets a UTI with a multi-drug resistant organism, you're in for trouble, right? So because of you're in for trouble. So that's why prophylaxis is not recommended. But if the child is getting recurrent UTI, you can consider prophylaxis. Asymptomatic bacteria should not be treated with prophylactic antibiotics. How do you follow these patients up? Patients with venous scarring and reflux require long-term follow-up. We monitor the blood pressure every 6 months if the patient has bilateral involvement, once a year if there's unilateral involvement, and you need to monitor the renal growth if the patient has a scar at least every 2 years. Further imaging is recommended for other structural abnormalities, and patients with recurrent UTIs, obviously, as I mentioned, are candidates for prophylaxis. So in summary, typical UTIs need minimal imaging and no long-term follow-up for prophylaxis. The current emphasis is on early diagnosis and rapid institution of treatment rather than extensive investigation and prophylaxis. Diagnose, treat, and be done with it. Atypical and recurrent UTI need further imaging with or without prophylaxis, and long-term follow-up is necessary for children with scars and other urinary tract abnormalities. Thank you.